not going to take much more time. I will pass it on to Jordan. She's going to talk about thrombotic risks with gender-affirming care. Thank you, Jordan.
Dr. Ramani. Okay, so the purpose of this was to review thrombotic risk stratification as well as mitigation in gender-affirming care. I think it's increasingly relevant in Vancouver because we're one of 2 sites as of 2019 providing gender-affirming surgeries to this population. Prior to 2019, it was solely completed in Montreal. There we go. So for the objectives, just a review of what gender-affirming care is, background, what hormonal therapy is, what the options are, and the rationale behind them, the thrombotic risk associated with hormone therapy in transgender patients and how they differ from the use in their cisgender counterparts, and then the management of these patients after acute VTE. And then lastly, perioperative considerations, primarily looking at gender-affirming surgery itself. So in terms of background, I'm sure we all know this, but just as a refresher, transgender refers to those whose gender identity is different from the traditional gender expectations based on the sex they were assigned at birth. It's estimated that around 2% of the population are transgender or gender diverse. And there's a 9-fold higher risk of suicide attempts in comparison to their cisgender counterparts, which plays into the importance of hormone therapy in this population. Gender-affirming care includes both social transitions, so living their lives as their affirmed gender, as well as physical transition, which is facilitated by medications and or surgery to support the transition of their body into their affirmed gender. Gender-affirming hormone therapy, or GHT for short, includes or induces secondary sexual characteristics consistent with one's affirmed gender, results in current research has showed a 60% reduction of the use of GHT in moderate or severe depression in this population, as well as a 73% of reduction in suicidality. It's also been reported that overall improvement of quality of life, life satisfaction, anxiety and body image associated with the use of hormone therapy. When we're looking at what hormone therapy entails in this population, specifically looking at transgender women, so they were assigned the male sex at birth, but their affirmed gender is in line with female. They utilize estradiol as their primary gender affirming hormone therapy. The routes that can be used in terms of administration include oral, transdermal, and muscular. And there are adjuvant therapies that can be considered in terms of testosterone blockade. Using primarily spironolactone is used in North America, from my understanding. And then cyproterone is one that is currently only really used over in Europe. It stopped being used here. And then GnRH agonists are primarily for those who are prepubescent. The goal is to achieve estradiol levels that are within the physiologic range of cisgender women, while developing the desired gender congruent physical effects of utilizing estrogen. The purpose of the anti-androgen adjuvants is to lower the overall testosterone in the body to help those physical effects be more prominent, which will go into the risks associated with those. When we're talking about transgender males, so those that were assigned the female sex at birth, the primary hormone therapy utilized in that population is testosterone, again, used to suppress estrogen production and induce the physical changes associated with their affirmed gender. It is available in intramuscular, subcutaneous, and transdermal formulations. And similar to estradiol, the levels are commonly followed, especially in the first year of use. And the target is to achieve a testosterone level that's within the physiological range of a cisgender man. Looking into the effects of hormone therapy, I've separated these to female and male, and comparing those to their cisgender counterparts. A lot of the data that we have for this population is extrapolated from cisgender data. Whether or not that is 100% appropriate, we'll chat about, but it's the knowledge that we have currently. In terms of the impacts of estrogen on hemostatic parameters, we know that estrogen is associated with an increased VTE risk. The factors that are increased and propagate a procoagulant state when estrogen is used includes factor 7, factor 8, and factor 11, as well as prothrombin and fibrinogen. There's also been associated activated protein C resistance and an increase in thrombin generation, as well as some effect on platelet quantity, reactivity, and von Willebrand's factor. There are natural anticoagulants that are reduced with estrogen therapy, including total and free protein S, tissue factor pathway inhibitor, and protein C. All of this results in a net effect of a prothrombotic state in those that use estrogen, both cis and transgender females. When we're looking at cis women and the use of hormonal therapy, separating them between the combined oral contraception and hormone therapy, when looking at the effects of estrogen in cis women who use oral contraception, the most common estrogen formulation that's used is ethinyl estradiol. It's known that there's around a 3 to 9-fold increased risk of VTE, which is dependent on both the type and dose of estrogen, as well as the type of progestin that it is combined with. From what we know currently, the highest risk is associated with combined oral contraception that is combined with ethinyl estradiol together with a 3rd or 4th generation progestin. And in contrast to hormone replacement therapy used in postmenopausal women, there's no differences in oral contraception based on the route of administration, whether it's transdermal or oral. When we look at hormone replacement therapy in cis postmenopausal women, the most commonly used estrogen in that setting is 17-beta estradiol. Ethinyl estradiol is not used as a form of hormone replacement. And in hormone replacement, there is oral and transdermal options, which confer a different thrombotic risk. Oral estrogen, that being the 17-beta estradiol, is associated with a higher VTE risk, around 2 to 4-fold. However, there's been studies showing the VTE risk that transdermal estrogen confers is much lower and insignificant, with an odds ratio of 0.9. And that difference is unchanged when stratified for weight, history of thrombosis, and thrombophilia, as well as other risk factors for thrombosis. The important caveat is that all those prior studies that were comparing oral to transdermal estradiol, the doses were not equivalent in terms of the doses of the oral and the transdermal were significantly different, and the levels of estradiol in those patients weren't actually monitored. So it's unclear if this is truly an effect of the transdermal estrogen route or a difference in dosing regimen. And just for some perspective, the highest dose of the transdermal estradiol that was studied in these prior studies that have illustrated this difference was around 0.1 milligrams per day. However, the most commonly used hormone replacement therapy in practice is 0.2 to 0.3 milligrams per day, so it over double than what was studied, suggesting safety. And of course, all of the background VTE risk associated with hormone use is further increased with traditional risk factors or predisposing factors. We know that obesity is in combination with hormone therapy, specifically oral contraception, increases risk significantly. One study I read, the presence of obesity together with obesity with a BMI greater than 30 together with oral contraception has an odds ratio of 24. As well as age, smoking in combination with elevated age, and thrombophilia, which has a large variation in risk associated with it. While the type of estrogen and the route that it is administered is important in determining the thrombotic risk, the risk between oral contraception and hormone replacement also changes over time. In premenopausal women, there was a prior large case control study from 2009, which included 1,524 patients and 1,700 controls, and they demonstrated that the risk of VTE was highest during the first 3 months of oral contraception use with an odds ratio of 12.6. The risk of VTE reduced over time, but largely plateaued after 60 months with an odds ratio of 5.2. So largely remained elevated beyond that. So it is still relevant, but not to the same degree. In postmenopausal women using hormone replacement therapy, the similar effects are seen, with the highest risk being in the first 2 years of therapy, and then again decrease over time, with no significant risk noted after 5 years of use. Although much of our knowledge regarding hormone use in gender affirming therapy is derived from cisgender cohorts, there's a lot of differences in terms of the types of estrogens that are used in transgender women, the doses, and how long they're used for. Additionally, we target a particular physiologic level, whereas in cisgender women, we just start it and then move on. Nobody is checking those levels thereafter. Another important difference is that while oral contraception and hormone replacement therapy in cisgender women, they're used for a finite period of time to get them through the postmenopausal stage, or to whether it's for a variety of reasons in premenopausal women, whereas in this population, it's planned for an indefinite use. And so that holds a different risk type. When we compare the types of estrogens that are used in cis women versus transgender women, the ethinyl estradiol, which is the most commonly used estrogen in oral contraception, is not used in hormone replacement therapy or gender-affirming therapy. Whereas in hormone replacement therapy, the most common one is 17-beta, at least in North America. The equine estrogen is not commonly used anymore. And that's shared with gender-affirming hormone therapy, with the most common being the 17-beta. Estradiol valerate, to my understanding and through my reading, isn't available in Canada, so I don't think that one's overly relevant for us. In addition, the doses are significantly different, whereas the dose of ethinyl estradiol in oral contraception is around 20 to 35 micrograms per day. And when we compare it to the dose of estradiol or 17-beta estradiol, it's obviously very different. However, the potency of these are also different beyond that. Ethinyl estradiol is estimated to be 500 times more potent than 17-beta estradiol. And the doses in gender-affirming hormone therapy, although the estrogen type is the same between that and hormone replacement therapy, the doses themselves are also higher. So extrapolating exclusively from data around cis women is largely inappropriate, given the differences in dose and what we know about increasing dose, increasing the risk of VTE in cis women as well. As in cisgender women, the type of estrogen used in gender-affirming hormone therapy confers differing thrombotic risk profiles. Ethinyl estradiol was previously studied and used as gender-affirming hormone therapy. However, it was shown through observational data that it had the highest risk of adverse outcomes, that being cardiovascular events, including VTE. A study completed in 1997 was a cohort study of 816 transgender women. And they documented an incidence of VTE of around 5.5 to 6% in those using ethinyl estradiol. The majority of those patients that developed a VTE were on the oral formulation of that. And just for some context, the dose that they were using at that time for gender-affirming hormone therapy was 100 micrograms per day, which is much in excess of even what we use for oral contraception now. In 2011, Ashman did a cohort study of 966 transgender women using, again, very high doses of ethinyl estradiol. And they also demonstrated a threefold increased risk of CV death, including VTE. So all of that conferred that ethinyl estradiol has been removed from the guidelines as an option in terms of gender-affirming hormone therapy. While conjugated equine estrogen is not commonly used in North America, the 17-beta estradiol is actively used in gender-affirming hormone therapy, and it's thought that this confers a lower VTE risk. There's been some low-quality studies that have demonstrated this, as well as looking at hemostatic alterations being less significant with 17-beta estradiol versus ethinyl estradiol. So ethinyl estradiol is no longer used. When looking at the effects of the route of administration in alterations of hemostatic parameters, Shears completed a study in 2021, which was looking at the net change of various hemostatic parameters in transgender women from the time that they started estrogen therapy over a 12-month period. The red here represents a net procoagulant change, whereas the green is a net anticoagulant change. The 1A, the furthest one on the left, is all trans women in the cohort. And then they separated on the basis of administration, so oral and transdermal. When looking at all participants, there was a clear procoagulant change with a significant increase in the elevation of factor 9 and 11, and a non-significant elevation of fibrinogen. There was also changes in terms of anticoagulant parameters with an increase in activated protein C ratio, a decrease in hematocrit, and an increase in free protein S. There was no significant change in factor 2, but overall, the net change of this was procoagulant. Those net changes were also differed by route. So if we're looking at the transdermal one, which is E on the left, there was significantly less alterations in fibrinogen and free protein S, with a greater increase in factor 9. Overall, this suggested that the procoagulant change that was associated with the oral preparation was not seen to the same degree in the transdermal preparations, suggestive that the thrombotic potential of transdermal estrogen was lessened. And that's similar to hormone replacement therapy in cis women, with the proposed reason behind that being the lack of first pass metabolism in the liver and alterations to coagulation factors in that way. The minimal effect on coagulation parameters has also been shared in clinical data. So again, the study in 1997, most of those patients were receiving oral ethinyl estradiol, with the caveat being at very high doses. More recent to that, in 2010, a cohort study of 162 transgender women who were all receiving transdermal 17-beta estradiol. And over the course of 64 months of follow-up, no VTE events were recorded, which we have very limited data in this population, but it was reassuring in terms of the VTE risk with the transdermal formulation. So based on low quality data and the suggestion that transdermal estradiol was safer in terms of thrombotic risk, that's made its way into guideline recommendations for high VTE risk transgender females to be receiving transdermal formulation of estradiol. However, there's been no head-to-head comparisons of specifically oral and transdermal 17-beta estradiol. GHT also differs from cisgender use of estrogen in that the VTE risk increases over time, with the highest risk being during the first, during initiation, or rather than the highest risk being during the first initiation that we see in cis women. This retrospective study, which was done in 2018, followed 2,842 transgender women and investigated the incidence of VTE over an 8-year period. And what they demonstrated was that the incidence of VTE increased over time with exogenous estrogen use, and that was persistent even once it was adjusted for potential confounders, including elevated BMI, hypertension, smoking status, etc. They compared this to cisgendered men and then cisgender females with a hazard ratio of 1.5 in comparison to cis men and 1.7 in comparison to cis women. In terms of anti-androgen therapy, cyproterone acetate, which to my knowledge isn't commonly used in North America, but it's an oral synthetic derivative of 17-hydroxyprogesterone and acts as an androgen receptor antagonist. It does have a similar VTE profile, risk profile in comparison to progestin use, and we probably won't see it here because to my understanding it's not recommended. The most common one that we typically see is spironolactone, which has no documented known VTE risk. In terms of thrombophilia investigations for cis women, as we all know, it's not recommended on a routine basis, although it is known to be additive to the risk associated with estrogen. There are some situations where it's argued that it is beneficial in terms of testing to inform or to better counsel patients and inform decision-making and more or mitigate risk by choosing a different alternative to a particular type of therapy, or one over the other in hormone replacement therapy or oral contraception. However, the transgender population is unique in that there's no alternative to estrogen therapy for, or there's really only one option, transdermal or oral estradiol. Due to the known increased risks of VTE in the context of thrombophilia, there's been a lot of mixed recommendations in terms of whether or not thrombophilia testing or screening is important or is relevant. Some argue through the literature that it would better quantify baseline risk, though it's quite contentious because saying somebody is at too high of a risk to receive hormone therapy also has grave implications in terms of suicidality and poor outcomes from a mental health perspective. In 2010, OTT did a study of 162 transgender women on transdermal estrogen. And within that population, there was no VTE identified over 5-year follow-up, and a prevalence of thrombophilia was around 7.2%, primarily comprised of low-risk heterozygote factor V Leiden. And that incidence is different than what we see in cis women in terms of the prevalence is a bit higher than one would anticipate. However, it doesn't seem to confer any significant increased VTE incidence, at least in that small cohort. Currently, guidelines do not recommend routine screening. However, it would be reasonable to consider screening if the patient had a prior VTE or they had a family history of high-risk thrombophilia or recurrent VTE in first-degree relatives. That's not to say that that would be a contraindication to utilizing GHT. However, it would just add another point to inform decision-making to counsel patients. Additional VTE risk factors that are relevant for this population is age. A lot of trans women are not diagnosed or do not receive adequate medical care until later on in life and are often at advanced age. Smoking is very relevant. Obesity, as I said previously, with an odds ratio in combination with estrogen of 24. And then other modifiable risk factors in terms of dyslipidemia, hypertension, and then lastly, HIV are also additive risk factors. Currently, in the event that a transgender female were to be considered a high baseline risk, VTE risk, the current recommendation is that all of them are placed on transdermal rather than oral hormone therapy, that their modifiable risk factors are paid close attention to in terms of obesity, hypertension, and dyslipidemia, as well as smoking. And the question of whether thromboprophylaxis, well, especially primary thromboprophylaxis, is indicated, we don't know the answer to that question. There's no data to support that use in transgender women. And so the guidelines sort of leave it up to a patient-physician discussion in terms of the risks associated with bleeding and the VTE risk. In terms of management of these patients after they have acute VTE event, the difference between trans women and cis women is that the main consideration is finding a balance through patient discussion, because there's a strong consideration to continue hormone therapy in this instance. Whereas with their cis counterparts, the common recommendation is to stop, hopefully after they have had another plan in terms of managing contraception or hormone replacement. Common things through the literature would be that these women would be transitioned to transdermal estrogen rather than oral. And if they are to remain on hormone therapy, anticoagulation is continued so long as their bleed risk is considered low. So when we're looking at hormone therapy in cis and trans men, in cis men, there's several proposed mechanisms in terms of the query that testosterone leads to an increased risk of VTE. Those are increases in hemoglobin and hematocrit, which we commonly see in cis men with hypogonadism using using testosterone. There's a question that there's increased peripheral 17 beta estradiol levels through a process of peripheral aromatization of testosterone. To my knowledge, that hasn't been exclusively proven. It's more of a theory. Another theory is underlying thrombophilia, because prior studies have indicated an increased prevalence of factor V Leiden or lupus anticoagulant in testosterone users with that develop a VTE on testosterone in comparison to male controls that have developed an unprovoked VTE. And then other theories include an increase in platelet thromboxane A2 receptor density as well as platelet aggregation. This was a prior meta-analysis that was looking at prior studies of cis men with hypogonadism receiving exogenous testosterone. They included 13 RCTs of cis men, and they did not demonstrate any significant association between VTE and testosterone use, with an odds ratio of 1.03 and a wide confidence interval. And based on this, the conclusion through the literature is that there's no significant association between testosterone use and VTE risk in cis men, but it remains largely mixed, with several studies saying there's a lot of case studies reporting VTE in patients with their only risk factor clearly being testosterone use. And so I think there's still a question mark as to whether or not it's implicated. When looking at the effects of testosterone in trans men specifically, This was the same study by Shears in 2020. They had a subset of transgender men looking at changes in coagulation profile. So again, the red is a procoagulant change and the green is an anticoagulant change. And they looked at this over the course of 12 months from the start of testosterone therapy. And what they found was a net procoagulant change with increase in factor IX hematocrit and an insignificant change in protein C, while there was a net anticoagulant change with increased activated protein C ratio, a decrease in factor 2 and 11, and increased protein S. Overall, this resulted in a no net procoagulant shift, at least biochemically, in this population. In 2021, this was a retrospective study that was done by Oakes, and they looked at hemoglobin and hematocrit changes in trans men using exogenous testosterone. And with the underlying theory that elevated hemoglobin and hematocrit or secondary erythrocytosis was a reason for or prothrombotic in some sense. So they looked at 519 transgender men and that were using testosterone. And they did find an associated significant increase in hemoglobin and hematocrit with a mean hemoglobin of 157 and a mean hematocrit of 0.47. And over time, the time to peak was 31 months. However, they also demonstrated in the same population of 519 men that 20% of them did have erythrocytosis with hematocrit greater than 50%, with a VTE rate of 0.9%, and a thromboembolic event of 0.9%. And those included 2 superficial venous thromboses, 2 distal, and 1 stroke. So overall, it did not clearly suggest that erythrocytosis resulted in a greater incidence of VTE in men who developed it while on testosterone therapy. Mullins in 2021 also did a retrospective study on 611 transgender patients, 70% of which had started testosterone hormone therapy. And they followed them over the course of 577 days and reported no VTE events in that population. And although observational data only, it seemed favorable that the VTE risk associated with testosterone was low. So the last part here is perioperative management, most specifically looking at gender-affirming surgery in and of itself. Gender-affirming surgery is a pretty big umbrella topic, colloquially separated into top and bottom surgery, which this is mostly relevant in terms of bottom gender-affirming surgery. So there's a lot of risk factors that are unique and not so unique to the transgender population. In females specifically, this risk might be more relevant given what we know about exogenous estrogen, but these patients are at higher risk given pelvic surgery in general. It tends to be quite intensive surgery with a long recovery process leading to prolonged immobility. Obesity is a risk factor for VTE postoperatively. Advanced age, which a lot of these patients tend to be, as well as perioperative travel to access surgeons, which is very relevant in Canada, given that we only started doing these surgeries in Vancouver in 2019, and before that, the only site was in Montreal, so patients were commonly traveling to and from Montreal for surgery. The use of hormone therapy perioperatively, and then other more traditional risk factors. The incidence of VTE in transgender patients really remains unclear. Prior meta-analyses have documented higher VTE rates in transgender women versus men, though all of those studies that were included in that meta-analyses had a very high degree of heterogeneity and a wide variation of types of estrogen utilized perioperatively for those patients and the method of perioperative management of hormone therapy. Historically, and really on the basis of nothing at all, the recommendation was that hormone therapy be discontinued 2 to 6 weeks pre-operatively and resumed once ambulating around 2 to 3 weeks post-operatively. It's really based on circumstantial evidence and based on the theory and of how exogenous hormones affect coagulation parameters, and that effect is reduced within 2 to 6 weeks after discontinuation. But it's very clear that these patients develop adverse emotional and physiologic effects around that time with discontinuation, and it can exacerbate dysphoria. A study in 2006 was qualitative, and they were looking at preoperative preparations, complications, and physical functional outcomes of male to female gender-affirming surgery. Of 232 patients included in this study, 214 were advised to stop and did, with a mean duration of interruption of their hormone therapy being 22 days. Of those patients, 35% of them reported that it was difficult, with the main symptoms being hot flashes, mood swings, irritability, increased facial and body hair, and an overall increase in dysphoria. However, despite that, there was a very small fraction of patients that did not stop. However, in the entire cohort as a whole, there was no post-operative VTE documented. A more recent meta-analyses of only 2 retrospective studies were investigating the VTE incidence among those who did and did not stop estrogen therapy preoperatively. They did not detect any increased VTE risk if therapy was continued perioperatively, with overall rates of VTE in that setting being similar to that of the general population undergoing benign gynecological procedures. But again, low quality data. There's a lot of variability in the available guidelines regarding perioperative use of estrogen, and all of these are primarily focused on cis women. However, the American Association of Plastic Surgeons did do a systematic review and meta-analysis of publications pertaining to perioperative VTE, and overall they recommended the use of the Caprini score, or Caprini risk assessment model. And that was in comparison to the European guidelines, which had a grade 2C recommendation regarding estrogen and recommended discontinuation perioperatively, again in cis women. Whereas the American College of Obstetrician and Gynecologists recommended against discontinuation of oral contraception in cis women, and did not recommend the use of the Caprini score, and did not make any recommendation of the use of the Caprini score for specific patient populations. The issue with the Caprini score in this population is that it's not specifically validated for trans female bottom surgery, which is at an inherently higher risk due to the like post-operative protocols and things like that, as well as, although there is a portion of the calculator as to whether or not somebody is on estrogen or not on estrogen, it doesn't account for different risk profiles of variable estrogen formulations and routes. I'm not sure which type it was validated for, but it's unclear if this is relevant for transgender females. So overall, transgender women, most of the data that we have is extrapolated from cisgender women. We do know VTE risk is dose dependent, and the main difference between transgender females versus their cisgender counterparts is that VTE risk increases over time rather than at the initial start of hormone therapy. And the lowest risk, as with hormone replacement therapy in cis women, is transdermal. There's no routine recommendation for thrombophilia screening, and thrombophilia, the presence of thrombophilia is not an absolute contraindication to using hormone therapy. And a special recommendation to pay close attention to modifiable risk factors that are associated with higher risk of VT in this population. And then perioperative interruption of hormone therapy for trans women is unlikely to be of significant benefit in terms of thrombotic complications post-operatively, and can result in more harm than benefit in terms of exacerbating gender dysphoria. In transgender men, there's no apparent increased risk of testosterone use if it's maintained within the physiologic range. And despite elevated hematocrit and hemoglobin over the first 12 months of using gender-affirming hormone therapy, this doesn't seem to confer a significantly elevated VTE risk in transgender men. And that is what I have.